name's Mike Oliver. I hope some of you have had the chance to read a little bit about me in the profile, so I won't waste time explaining who I am or my history, other than in a very brief way. The reason we're having this session is that we decided that, having just been through a pandemic, greatest peacetime struggle since the Middle Ages probably, we ought to have a brief look at how all of us, or some of us, and hospitals and optometrists coped during that time, or didn't, and how those struggles affected people, and where we go from there. And I think you're going to hear, I hope, from three speakers. You're going to hear from me. That won't be too long, because it'll be about my personal experience during lockdown, how keratoconus went for me and how it interacted with other medical problems, and how the whole thing worked or didn't during that time. We should then hear from, if she's here, Julia Smythe, and our clinic liaison officer from Moorfields, about how things worked for her and the clinic she's responsible for. And finishing with a talk, which those of you who have heard him before know will not be short, from thank you, from Ken Pullum, who is an optometrist with unparalleled, in my view, experience in the area of keratoconus and particularly scleral contact lens. So that's how we're going to run it, and we hope there will be plenty of time for a question and answer and general discussion session after that, which is often the most interesting, apart from hearing all of us speak, which I'm sure is completely wonderful. I'm not going to offer you further death by PowerPoint. You're just going to listen to me. It's not necessarily a pleasant experience, but I'll do my best to get through it without sending you to sleep. But if you do nod off, please don't snore. So, as I've said, we've just been through a horrendous time from March 2020 on for 2 years, and we're on from that. Things still haven't got, as it were, back to normal, quote unquote, whatever normal is. So what I was going to do, because we wanted to look at people's experience, is to go through mine, because I had problems before lockdown, during lockdown with keratoconus, and then encountered other potentially more serious health problems, which all had to be dealt with at the same time and interacted with one another. So I was diagnosed with keratoconus in 1964. Since then, I've worn scleral contact lens continuously. I've managed to avoid surgery about 5 times of one sort or another, mostly due to the ingenuity of people like the speaker you're going to hear later, Ken and his colleagues, in developing ever more sophisticated scleral lens of one sort or another. Indeed, Ken's practice awarded me a 50-year scleral lens wear t-shirt 9 years ago, and I just want to put in a bid now, because next year, if I'm still about, it'll be 60, so I want a new one. So in any event, just before lockdown, it's about 6 months before lockdown, I got a new pair of lens, which had been provided by Moorfields, and that was fine, and they came in the post, but they weren't really fitting very well. So there were some changes made, and I got the replacements, would you believe it, in March 2020, just after lockdown started and absolutely everything closed. So I tried these, and again, they weren't really working for me. One was very uncomfortable, the other one gave no vision. And so I went back to some very old lenses, which are also ill-fitting, but I could just manage one at a time. And so I managed to get through. And I thought, well, I've got an appointment in May, it's only 2 months away, everything's going to be fine. So much for that, because by that time, everything had closed. There were no clinics, and just before that appointment, the letter, which was the first of 3 or 4 I had, I think, like many people, I'm sure, came along and told me that that appointment wouldn't happen. It would be 2 or 3 months down the line, and then it happened again, and it happened again. So I was in a very fortunate position, because I have been around the keratoconus field, a trustee of this group since its beginning and so on. I got to know a few people, I had some phone numbers and email addresses, and I spoke to people and was given some advice, and I was able to manage with the old lens, and I was basically told to sit tight and wait till you could come into the clinic. Didn't happen. it just went on, and I don't criticise anybody for that, although with the benefit of hindsight, I would say perhaps there were mistakes made there, but that's not for me to say, and I don't see the bigger picture perhaps. But I do know many people who were in the same position who couldn't get the treatment they needed because it was regarded as routine, and the routine clinics simply were not there. Unfortunately, it seems to me that routine means keeping people going, and if you can't keep people going, you then have a crisis which has to be dealt with in a more serious way. Fortunately, with keratoconus, I was able to struggle on with lens, and I complained incessantly about this until I realised that that was by far the least of my problems, because in July 2020, which was also in lockdown, I was diagnosed with colon cancer, and that sort of changed my outlook so far as keratoconus was concerned, because then it became a secondary problem. And that got, while doctors decided what to do in lockdown and with certain treatments not available, they tried to work out what to do. It got worse and worse, and I ended up walking into, on a Friday evening, not the best day in Lewisham, walking into Lewisham A&E, and to their eternal credit, I have to say, within 1.5 hours, I was triaged, seen, tested, admitted, and on a ward receiving treatment, literally. So if anyone says that in an emergency the NHS don't work, don't believe them, because certainly for me it did. Now, how is that relevant to keratoconus? Well, it's relevant in this way, because I went in on a Friday evening, I had emergency surgery 36 hours later on a Sunday. On that Friday evening, I took out the one contact lens I was wearing. I was not physically in a position to sit up and put in a contact lens for another 8 days. That meant, because mine is at the stage where all I see is a blur and nothing else, that meant I was effectively blind in hospital, flat on my back, for about 3 or 4 days, and then gradually being able to manoeuvre about after that. I can only describe this as being in a fog. It was weird. I was in a mental fog anyway because of the illness and the treatment, and I was now in a physical fog as well, it seemed, from my eyes not being able to see anything. I must have been treated as the grumpiest old man on the ward, because every time a patient spoke to me, apparently to me, or a doctor or a nurse or anybody else, I ignored them because I didn't know they were talking to me, and I didn't want to seem like a fool and respond. I had great difficulty conveying this to a nurse, a ward full of cancer nurses who were not used to dealing with eye conditions. They got it eventually, to their eternal credit, and were really helpful to me. There was nobody in the hospital who had actually seen a scleral lens. They tried to get an ophthalmic doctor to come and look at me, and he just didn't know anything about them, which is fair enough, he didn't. So, but that also demonstrated to me the sort of shortcomings of the service at that point. And so after 4 or 5 days, I managed to get one lens in, and I can only describe it as the same feeling as I had when I was 10 years old and I put my first scleral lens in. The world suddenly had sharp edges. Tree branches, particularly, I always remember this. Tree branches, I could see their edges. They were sharp. Never seen this before. And it reminded me of a second thing, which is something Ken, who you will hear later, told me about patients with Down syndrome, high incidence of keratoconus in Down's patients, I'm told. That when he can eventually get a lens into their eyes, they gaze around in amazement, and it causes a change in behaviour because suddenly they are in a different place. And that place makes sense. And that is the magic. And to me, as a layman and not a scientist, that is what it is, the magic of having that type of lens and that type of potential treatment. That's where it lies. And that's how I would describe it. So there we are. That was how I felt in hospital when I was able to put a lens in. I went back to some sort of normal lens wearing with the old lens, but I was unable to see anybody until I saw Ken and one of his colleagues in clinic much earlier this year, after lockdown. So that's effectively, it was almost 2.5 years since I'd seen anybody. I'd been through 2 pairs of scleral lens which hadn't worked too well, which wasn't anybody's fault, that's just how it turned out. And I was given another pair, or rather, I was eventually given another pair, which came a couple of months ago because of my other treatments. I couldn't collect them. I eventually did collect them last week. I now have those lenses in, and as I said to Ken earlier today, they are brilliant. I now have another pair of working scleral lenses with, as the last speaker described, slightly less vision, but a damn sight more comfort. And I don't mind having an extra strength on my reading glasses. It's absolutely fine. But those lenses work. And a lot of the things the previous speaker said, I so much agree with. It's all about a compromise with this type of lens, and it's all about making them work. The other thing I wanted to say about treatment, medical treatment, eye treatment, any treatment during lockdown, and probably afterwards as well, is that, well, it's really around the issue that's become a national issue, mental health and admitting you need help. I've never had any problem with that. I've had counselling and psychotherapy at numerous times over the last 40 years. I don't have any problem saying that. And I knew when I woke up in hospital after that operation, I needed to talk to somebody, and I needed to talk to them fast. Because trust me, and I'm sure some of you have been there, it is a very dark place. We're not quite sure what's going on and whether you're actually going to come through it. And so I spoke to the local mental health services, psychology services, whom I'm involved with in a service user group and had been for a while. And they said, yep, we can see you in 8 weeks. Forget it. I needed somebody now, tomorrow at the latest. Where are you? What happened? Macmillan happened. Someone from Macmillan came and saw me that day. I saw her in counselling the next afternoon, and I've been seeing her every week ever since, and indeed I'm seeing her on Monday afternoon, and I probably would not have got through this episode, this scenario without it, having since been through chemo and about to enter another session of chemo. So the NHS can work. Help is there. You have to go and find it. What amazes me is that for relatively routine treatment, to me at any rate, for keratoconus with my scleral contact lens, there was no availability. For acute cancer, it was there immediately. Now, you may say, well, it should be, but there has to be a compromise somewhere because minor situations become major situations. I was lucky. I knew people I could refer to. I could pick up a phone, talk to Ken or 2 or 3 of his colleagues who I know reasonably well and say, help, what do I do? Truly, that's a privilege. People don't have that option. And so I just think that perhaps some thought ought to have been given. And it may not only apply to eyes, it may apply to all sorts of different conditions for different reasons. I just think there ought to have been greater availability somehow for everybody, rather than simply closing everything down and concentrating on one condition, however incredibly serious that condition was. So that was my experience going through it. It was truly, and this sounds melodramatic, but it was truly life-changing for me. It has turned upside down the way I look at things, not just for my eye condition, but in every respect. And since that, I've become involved in a number of NHS psychological initiatives and sit on different committees and groups and try and put something back in, because it seems to me, and this is a battle people have fought for a long time and no doubt will continue to fight, that treatment needs to be centred much more on what the person needs, and their quality of life. And what I needed, having a potentially lethal physical condition plus my keratoconus, plus mental health issues, I needed somebody to put those together and work it out. Now, okay, I'm asking a lot in the middle of a pandemic, or am I? We have a National Health Service, and if it was run in the right way, things could happen in a rather different way. This isn't the forum to sort of campaign in that respect, but it certainly has made me look at things very differently. And I just thought it would be useful to try and put some things in context. I'm not looking for sympathy. Empathy would be nice, but I'm sure there are lots of people who've had worse stories during COVID. I've never had COVID. I've had nobody in my family or close circle who've died of COVID. Many have. But it wasn't the only condition about, it seems to me, and everything needs to be looked at. So that's my brief history. And I hope that means something to some of you. But I don't think I'd be unique, because there must have been all sorts of people with keratoconus and other eye conditions who needed help and couldn't necessarily get it. However minor that need was, it needed to be addressed so they could go on and live their lives, however difficult that was during the pandemic and lockdown.
COVID had a significant impact on not so much keratoconus, but delivering the services of keratoconus. It was not all bad, actually. There was some interesting benefits, unexpected benefits that came about from it. I was actually suspended for most of the time in the first lockdown, not because I'd done something that I shouldn't have done, but I turned up on the, sorry, excuse me, on the day before lockdown because I had 4 or 5 files in my in-tray, and I came in late, so there was nobody on the train, and we'd already cancelled all the clinic appointments. And I was thinking, if I don't sort these files out today, it could be a couple of weeks before I sort them out again. So I came in, I walked into the Red Clinic at Moorfield. Marcello, who can be a real dragon at times, you know, he said to me, "What are you doing here?" I said, "Well, actually, Marcello, I've just come in to sort out a few files." And he said, "Well, take the next train back home to Hertford, okay? There's one in 10 minutes. And I didn't. I had to finish off my jobs of sorting out these odd files here and there. It took me an hour or two. But I didn't go back again for quite a long time. It was more than 2 weeks, quite a lot more. And in that summer, I had a hip issue, which when I stopped going up the stairs at Old Street Station, it suddenly went downhill. I don't know if there was a connection, but I couldn't have gone in anyway because it was so immobile in that period. But there was 3 months off before we even saw any new patients or old patients, for that matter, except emergencies. And the clinic closed between March and the end of end of August. And then I couldn't have come back anyway. Then I had this hip op, and that was massive improvement. But then COVID came back with a vengeance in the autumn, and I thought, I'm going to give it a week or 2 or 3, and then the vaccines kicked in, and I had one of the first vaccines, and the booster 3 weeks later. Then just as they changed it to 3 months, and I thought, I'm going to have another 3 weeks off here because I'll just let this kick in. So it ended up between March and end of January that I didn't set foot in the place. I've never done that before. And honestly, it was like coming back from time travelling. There was one-way systems. There was no escorts or accompaniment allowed in the consulting rooms. You had to get past the trained dragons on the front desk at the entrance to the hospital. And they were trained to kill, I can tell you. So it was really difficult to run the clinic. And we still have the one-way system. We still have a little bit toned down, but we still have the dragons on the front desk. Not the front desk of the clinic, they're lovely. It's the people on the front desk of the hospital not letting people in. So it might have been pouring down with rain, but there was a queue halfway up City Road to get into the hospital. And so it was difficult, and we were trying to cut down the contact time with each appointment. It didn't work on me much, I must say, but it worked on most people, as you know well. And so we did less clinical work. Then we discovered the telephone. And we discovered that we could phone people and find out what their problem was, and we could find out whether they really needed to come in. And a lot of the time, they didn't. There's a limitation in telephone consultations. You can't measure visual acuities, and you can't see whether something that nasty is going on which you need to pick up in its early stages, but they certainly do have a benefit. And if we were to collectively link this telephone consultations with a little bit more community action as well, integrating with community optometry. And I was picking up bits and pieces of the earlier presentations today. I'd say that community optometry is about 100 times more switched on to keratoconus now than it was, well, certainly 30 years ago, because it was nil then, but even 10 years ago. And so there is a lot of potential working with the community with keratoconus. And I think it would be a lot better than dragging people in to Moorfields Eye Hospital from all over the southeast of England if we were to set up some kind of integrated action with the local community optometry. And we could find ways of, as I alluded to earlier, we can find ways of improving connection with the community optometry to everybody's advantage. And this is one of the big differences that happened with COVID, that we're very much more conscious of. It hasn't happened yet at Moorfields, I don't think, but I think there's lots of potential for doing it. In the London area, there's half a dozen practices in the periphery of London which are owned or manned in some way by Moorfields staff. I have one, and Nick Matt Carter has one in South London, in West London there's people, East London's Heather. There's quite a few people who would be able to integrate. And I think we need to move more towards that. And as far as the Keratoconus self-help group is concerned, I think this is something which you could look into and try to make it happen, because I think it would be to everybody's advantage. It would mean we would have less busy, frenetic at times clinics at Moorfields and other hospitals, Leicester and Nottingham. Same applies on slightly smaller scale, but just as frenetic though, just less of it. And we could achieve so much more by integrating a lot more. And this is the one thing with COVID that has a positive benefit, that we're all thinking more along those lines to see if we can integrate better with community optometry. And I think this would be very good. It needs to be more information disseminated from Moorfields and other places. We're doing this. We've done a lot of it in the past, I don't think, but this is something which we need to step up now. And this is one of the changes, the major single change that has come out of this unexpected event with COVID. And it's just become, the clinics are more complicated for some. I'm not quite sure why that is. Everybody is more aware of what's available, like Russ's presentation just now. People are much more aware of scleral lenses. 20 years ago, it was a what's that? Nobody heard of them. Now everybody's fitting them, and it's sort of taken over. I'm inclined to say, excuse me, wait a minute. There still is a place for corneal lenses within the management of keratoconus, and we do it quite often at Moorfields Eye Hospital, actually. But it has changed things. So we need more communication, which is slowly happening, but we need more integration with the community, and I think this is something which has been triggered off, and I hope we can work on that one in the future, rather more than we have been up till now. I don't think there's anything else I can add to that. Keratoconus hasn't changed much because of COVID, still just as awkward. That hasn't changed at all. Oh, well, the materials, yes, we are having some issues with the materials. I don't think I should get too drawn into that discussion at the moment, but yes, we are. And this has made life a lot more complicated still. Had quite a lot of people where they had lenses which were perfectly okay, ordered them new lenses. Nothing's changed, or it has, the material's changed. And there's a lot of people, you're not the only one, Sue, it's dozens of people. Every day I'm there, someone says, you know what, this lens is not as comfortable as the previous one. It spoils. It's got a grey spot on it. I can't get rid of it. That's how people describe it. So something's changed, that's for sure. But I don't really want to go too much into that one at the moment, because it's work in progress to try to see if we can resolve it, and we are working on that. So that's all I have to really say. COVID came and has it gone? Fingers crossed, page to the right, gods. COVID came and went, I suppose, still here with us. But there have been some positive changes as a consequence. So that's my, I don't have to add much more to that, I don't think. Unless there's some questions, I'll take some questions. There's one. Anne? Oh, is there another microphone?
Wasn't sure whether somebody in front wanted one. Okay. One thing I was wondering, I mean, one of the potential effects of COVID is the youngsters who weren't getting diagnosed or weren't getting the cross-linking at the time that they needed it. Has anyone been looking at that aspect?
Well, yes, the question was, did the COVID pandemic affect the recruitment for the cross-linking programme? Well, I think probably did, but we were trying to attach a priority to that, because as you probably picked up, there's a window of opportunity for the cross-linking. If the cornea goes too thin, most of the clinics are reluctant to administer the cross-linking because of the potential damage to the endothelium. So you see, it could be that there were some delays on that, but the cross-linking clinics haven't picked up anything really that has suggested a serious problem as a consequence of COVID. Not at Moorfields, anyway. Martin?
I mean, like Ken in Leicester, we did a lot of telephone assessments of cornea patients, including patients on waiting lists. And I agree with Ken. I've not noticed with younger patients a significant problem creeping up over the last couple of years. And they've been triaged, so the younger patients have been seen as soon as possible. Yeah. Yeah.
I think one of the other points is, if you look at other disciplines within eye care, so there's been research done during the COVID pandemic in terms of the increase in myopia prevalence. That has gone up during the pandemic in children. Screen time has gone up in children. Dry eye has gone up in children and in adults because we're doing so much more. So, that obviously leads to things like more eye rubbing. So I just don't think that data has quite come through. But I would not be surprised if, when we look at progression in non-cross-linked children, whether there has been a greater degree of progression. I wouldn't be surprised because of these other factors.
Yeah, you may well be right, but the feedback I'm having from the cross-linking clinic, which everybody's pleased that I'm not involved with at all, other than to channel people towards it when appropriate, because it's not. I'm glad to do what I do rather than the cross-linking program, actually, but I haven't picked up all that much in the way of negatives. I was involved, well, not involved, but I was witness to a horrible one which was not connected with the cross-linking, where a person had put off his appointment, or rather he'd had his appointment put off. This was post-transplant, and this had been put off, and then it was postponed, and then it was put off again. And then in the end he turned up, and this was a young person at age 30, and he'd lost an awful lot of vision through a glaucoma complication of his transplant. Now that was an absolute disaster, but that aside, I haven't picked up on all that much that has gone seriously wrong because of COVID. And because there's the window of opportunity with cross-linking, there is a sense of urgency with that, which doesn't apply to other aspects of management of keratoconus. You can have your lens left off for a couple of months and nothing serious will happen. Miss that window of opportunity, and there's potential for all going pear-shaped. So there's that one thing, there isn't that much else, where there's an acute requirement for treatment and management with keratoconus. And I haven't detected. I have to ask Marcello, he may well know more about it, but I haven't noticed anything.
I think the point is that it's a population study that needs to take place, so that's a lot more, a population study rather than, personal experience. I think that data takes a long time to come through. So, and I'm sure there are people looking at it within the NHS, because that's why all these IT systems and things that we have are there. But I just don't think we're aware of it. That's the point.
I'm sure you're right, yes. I've got all the information on that.
There's been an increasing problem, and I have discussed this, is if someone's on a waiting list for a corneal graft, there's a serious problem, has been over the last 2 years, about getting materials, getting donor corneas. Some people will be aware of that here, for a couple of reasons. One is to do with COVID, and then the other one is the dreaded Brexit regulations. I'm not quite clear about the details, but there is a significant shortage of donor corneas, which will have an impact, of course, on management.
Yeah, it's an interesting point you touch upon there, yes. But a transplant, waiting for a transplant for another few months isn't that urgent, but there could be an explanation why there's a shortage of donor material, which is that people were confined to home, and, well, need I say any more on that? The obvious, gruesome, but it could be that there was less transplant material available for that reason.
Yeah, thank you very much, Maya. It's really, really good.